This material is for reference and educational purposes only. SimKit, its authors and associates assume no responsibility for the utilization of any knowledge, materials, or techniques shown or described. Nor do SimKit, its authors or associates assume any responsibility for patient safety or outcomes. Clinical experience as well as current guidelines should determine the exact procedure and processes in each individual patient.
Hello and welcome back to the SimKit podcast and our podcast today on efficiency in patient care and charting. So the goal of this podcast is to talk through how we structure our day and the way we move through patients and the way we move through the documentation process for them. One of the major goals here is to get us more efficient in the way we chart and allow us to chart in real time for the avoidance of this after shift, many hours catching up or completing notes. We all know that emergency medicine is tough. It's so hard. Spending that time working through patients, giving your blood, sweat, and tears to them is an important part of the job. Spending 2 or 3 hours after the end of your shift charting on the patients is not something that we have to do. It has a major impact on our job satisfaction, our quality of life, really, and our burnout. So getting out on time is an important and underrepresented or underspoken about part of job satisfaction. And this is something that can be within our control. Another element of this podcast is I work actively with learners and residents all the time. On shift, I ask them routinely, what are you working on? And what can I give you feedback on today? By far, the most common response to this is efficiency. It's not something that's easily taught in medical education or residency training. Being efficient in the way you move through patients and the way you document patients is important and something that we should offer more robust education in. So that's the goal of this talk today. So diving into it, I recognize that every patient has 4 or maybe 5 elements of care that we need to do. We need to sign up for the patient. We have to see them. We have to do orders for them, our note, and then possibly or probably do a reevaluation or an update. Sign up, see, order, note, or SUN. So how do I structure this in my practice in a way that pushes me to see more patients, but also to chart efficiently so I'm trying to get out on time? So sitting down, start of shift, I sign up for my first patient. I'm going to do my quick chart biopsy, check their medication list, check their medical history, see when their last visit was, and look at the triage note. And then I'm going to go and see patient 1. I'm going to do excellent bedside manner. I'm going to sit, try to stay off the computer and actively listen to the patient, meet them at eye level, et cetera, et cetera. After I've done that great bedside manner, reviewing and examining the patient, I'm going to sit down at the computer and I'm going to sign up for patient 2. I then go through and do my orders and note for patient 1. I do that note all the way through my initial MDM. I like to think of it as just regurgitating. I take the HPI and I put it in there, review systems, physical exam, super fast. And then the MDM is patient comes in with X, Y, or Z. The differential diagnosis includes A, B, C, D. We are going to be doing these things to work them up. That gets my mind out of it so that at end of day, I don't have to go back through and try to remember the patient, read that triage note, dig back up my HPI. It's going to make me much more efficient at concluding the note. I can pop in there after the patient's care is done and say, laboratory work and imaging showed this, and our plan is this. So in that way, I have it teed up and ready to be concluded quite rapidly. After I do order and note for patient 1, I'm going to go and see patient 2. Again, great bedside manner. I'm going to talk them through. I'm going to listen actively. And when I come back and sit at my computer, I'm going to sign up right away for patient 3. Push myself to see these patients who are waiting to be seen. I'll sign up for patient 3, do order and note for patient 2, and then I'm going to go and see patient 3. Same process can repeat itself. When I sit back at my computer, I'm signing up for patient 4, doing orders and note for patient 3, and then going and seeing patient 4. So that's the flow and that's the algorithm. By sitting down and signing up for your next patient after you've seen that last one gets your mind primed, gets you ready to get up and be maximally efficient, to improve that throughput, to increase your number of patients seen. Now, of course, there are a couple of caveats to this. When you sit down at your computer and you're signing up for the next patient before doing order and note, you have to recognize that if you have a program where there's a trigger set up for your hospital, where you're going to get pulled in multiple directions, you have a critical case that you just concluded, maybe that's not the right time to assign yourself to someone before you do orders and note for the last, right? If you're going to get pulled away, you don't want to have signed up for someone and leave them hanging, so to speak. Generally speaking, that's going to depend on the number of patients you have and their acuity. I find that when I start a shift, if I start a shift without sign out, I can do that process quite efficiently and quite accurately. I might have to stop to sign an EKG, but then I could do order, note, and go and see that patient for whom I just signed up. It really helps keep me moving through patients and improves my patients per hour. The other important thing to recognize is that you do definitely reach a critical mass. You cannot do this ad nauseum for all the patients waiting for a provider. For me, I find after doing this for many, many years, my critical mass or sweet spot is right around 8 active patients. Of course, all of this is with a grain of salt, right? If you have an incredibly critically ill patient, that number is going to go down. If you are the first provider of the morning and you just got signed out on case management patients, psych patients, and admitted ones, then your number of critical mass is going to decrease because you have to work with case management. You have to talk to your psychiatric colleagues. You have to do all of those other things. So the critical mass is going to shrink or grow depending on how many patients you receive and sign out and how sick the patients that you get really are. Now, a little bit of a commentary on reevaluation and touch points with patients. One thing that comes up is how many times should I be re-evaluating or updating patients? And I find that there's a magic number. And that magic number to think about is 6. Not 6 reevaluations for every patient. That would be crazy. But 6 total for a patient considering their ESI. The patient's ESI, which we know goes from 5, which is rash for a year and a half, medication refills, sometimes punitive by the nurses, depending on why the patient's there, all the way up through 1. 1 is stroke, STEMI, respiratory distress, anaphylaxis. We all know what these patients are. So the patient's ESI score plus their provider touch points should equal roughly 6. As an example, that level 5 patient who has a medication refill request, I can go see them, evaluate them, and have that single touch point to conclude their care. ESI 5, 1 contact point with them, 6. If you have an incredibly critically ill patient, you need to be in and out of the room routinely. That's probably 5 total times. You have a level 3 abdominal pain. You get to go and see them. At some point, you're going to go back in and check on their pain, check on their nausea, update them on labs, and let them know we're waiting for their CAT scan, for example. And then when their care is concluded, you're going to wrap it up and make sure all questions are answered. ESI 3 touch points with the patient for a total of 6. Again, of course, grain of salt. We have to recognize that different patients have different needs and complexity matters. But if you use that general rule of thumb, you can think about the number of touch points you have with a patient related to their ESI score. So as much as patient care and charting efficiency is a very complex element of emergency medicine, we can break it down somewhat simply. We recognize that every patient we have to sign up, see, order, note, plus or minus reevaluation depending on their ESI score. If we work our way through patients in that way, sign up, see, when we sit down at the computer after seeing a patient, we sign up right away for our next patient we're going to take care of. Then we can do our orders and note all the way through MDM for that first one and go and see the next. We're going to repeat that cycle until we reach our personal critical mass. That's going to depend on how many years you've been doing this and how sick your patients are. Finally, We recognize that the touch points for patients are going to be variable, but if we can think about that magic number 6 roughly, that's going to outline how many times we should be touching base with patients and inform the number of times we really should maybe be in and out of the room. So collectively, think about how you approach patient care, patient throughput, and charting efficiently, because it really, really matters. Spending that extra time after shift, it just sucks your soul. So I hope that this structure, which you can bring to the bedside with the infographic we provided, is helpful for you to improve your patient throughput, the efficiency of your charting, and how often you get out on time. Thanks for listening.